So, good afternoon to all. We, Shailya Rasashala, are engaged in manufacturing of Rasaushadis at PAR, as you all know. Besides this, as a part of continuous education, we arrange series on different clinical topics. This month, we have arranged series on autoimmune diseases. It is our pleasure to welcome Dr. Purva Chaudhary, madam. Uh, she has completed her MBBS from uh, Ahmednagar and completed her MD in pathology from Lokmanya Tilak Municipal Medical College, Sion, Mumbai. She has an experience of almost 8 years in the field of pathology. Her special interest is in cytology and histopathology. Currently, she is lab director and consultant pathologist at Swananda Pathology Laboratory, Dombivli East, which is a NABL accredited fully automated laboratory in Dombivli East. With this brief introduction, I request Madam to start her session. Thank you. Madam, please start.
Yeah. Good afternoon, everyone. I think I'm audible. Am I audible to everyone?
Yes. Stop here.
Okay. Good afternoon, everyone. It's a pleasure to have this opportunity to give a presentation on this topic to all the esteemed members. Thank you, Shailya Rasashara, for giving me this opportunity. Okay, so as we are talking about very important topic, autoimmune diseases, which is on steep rise in this upcoming years, the blood investigations in autoimmune diseases are very, very important because they give a proper insight into the disease for a clinician. And also, it is very important to choose which blood investigations are to be done in various autoimmune diseases. So today we'll have a brief introduction to all the autoimmune diseases, its diagnostic criteria, and what test we can do when we suspect any autoimmune disease. So thank you everyone. This is Dr. Purva Chaudhary, as sir rightly introduced. Okay, so first of all, why a blood test in autoimmune diseases? Because it's of great value when evaluating a patient with a suspected autoimmune disease, right? So why do we do blood tests in autoimmune diseases? First of all, to confirm a diagnosis, to estimate the disease severity, to aid in assessing the prognosis, and also useful to follow the disease activity. So we can see right from the diagnosis to the treatment and to assessing the treatment outcome, we need the blood test. All right. So the role of blood test is very important. So when it comes to autoimmune diseases, this is a panel of laboratory examination that we will discuss. First of all, the general test comes into picture, starting with complete blood count with differentials, a comprehensive metabolic panel, inflammatory markers like CRP, which will be helpful for us in assessing the degree of inflammation. Then next and most important is the autoantibodies detection. Now, autoantibodies detection can be by immunofluorescence or by enzyme immunoassays, chemiluminescence, immunoblotting, double immunodiffusion, counter-immunoelectrophoresis. So all these are all new advanced techniques which give almost 95 to 98% sensitivity in the testing. Right, and last and foremost is the flow cytometry, which is conducted in few autoimmune diseases. So, of course, we will start with the golden sentence in autoimmune diseases. A comprehensive laboratory evaluation in conjunction with the thorough clinical evaluation provides a better understanding of patient's immunologic disease. So, a clinician's eye and a laboratory's microscope, both of them, they play a much better role in patient's immunologic disease. So, of course, we all know what is autoimmunity. I'll just go through once. It is just as simple as the immune system is turning against its host. There's a loss of normal immune homeostasis so that the organism is planting an abnormal response against its own cell tissue. Yeah, generally this is involving the self-reactive T cells, the autoantibodies, and of course the inflammatory part is very important. Now, whenever we go to classification of autoimmune diseases, we have two types. The first is the organ specific, and next is the non-organ specific, or what we can say is a systemic immunodiseases. Right. So, in organ specific, we have all the major organs involved in the autoimmune diseases, and non-organ specific, the two most important we will discuss is SLE and rheumatoid arthritis. So first of all, let's take a look at the organ-specific diseases first. First and foremost, I'm starting with the most largest organ of our body, that is the skin. So these are the all the diseases that are caused in skin in the autoimmune category. So when we talk about pemphigus vulgaris, it causes antibodies against the intracellular spaces and the desmogleins proteins. Detection methods for these are DIFM. DIFM here I refer to as direct immunofluorescence microscopy. IIFM is indirect immunofluorescence microscopy, and ELISA. Similarly, for pemphigus foliaceus, which is again a similar disease to pemphigus vulgaris, the antibody is directed against the DSG1, that is the desmoglein 1 protein, and detection method is DIFM on skin biopsy. Paraneoplastic pemphigus, autoantibodies against the ICS, that is the intercellular space proteins and the basement membrane zone proteins. Again, we can detect it by DIFM, direct immunofluorescence on skin biopsy, and immunoblotting. IgA pemphigus, in that we have autoantibodies directed against the IgA intercellular spaces. Again, DIFM is the detection method of choice. For bullous pemphigoid, we have the autoantibodies against the basement membrane zone hemidesmosomal proteins, and DIFM on skin biopsy is a detection method. For mucous membrane pemphigoid, again it's the same autoantibody and same detection method of direct immunofluorescence. So, whenever it comes to skin, we proceed in this way. The primary diagnosis is given by history and the clinical picture. Once you are suspecting it to be an autoimmune disease, we go to histology. This is skin biopsy, and as I rightly said, we do DIFM, which is direct immunofluorescence, and indirect immunofluorescence. Now, once we confirm the diagnosis by these three methods, we can do again a confirmation by ELISA, immunoblot, or immunoprecipitation. So, a primary picture, a confirmation of primary picture, and confirmation by ELISA will give you the specific diagnostic. And the diagnostic course is again further assessed by immunoserology or ELISA or immunoblotting or immunoprecipitation. So again, these three things can be used again to assess the diagnostic course of the disease. So this is how we will go for the skin autoimmune diseases. Now, the next organ that we are going is kidneys. Now, in kidneys, the most important autoimmune or disease that we see is the anti-globular basement membrane glomerulonephritis. So, in short, if I have to say about the mechanism of it, there are the antigens in the basement membrane glomeruli, and the body has an anti-GBM antibody. Both of them form an antigen-antibody complex. This antigen-antibody complex, along with the complement C, which is a complement cascade activation, will form again an antigen-antibody complex along with the complement. This immune complex will lead to inflammation. It will lead to anti-GBM glomerulonephritis, and even it will lead to vasculitis. So this is the mechanism of this autoimmune disease. So this is the anti-GBM disease, which is autoantibody against the glomerular basement membrane, and detection method for this is ELISA. Nextly, when we go for liver, very important topic is autoimmune hepatitis. So as we can see that these are the hepatocytes, right? These are the hepatocytes, and we have an autoantibody directed against the hepatocyte antigens, right? So this is the very shortly the mechanism of autoimmune hepatitis. So here we get a very variable clinical presentation, right from subclinical disease to acute liver failure. There are symptoms of chronic inflammation like fatigue, myalgia, arthralgia, right? IgG is typically elevated in these patients. right? So, and as I said, females are more prone to autoimmune hepatitis. So that is again one thing that we can see when we diagnose autoimmune hepatitis. There's a bimodal age peak, 10 to 30 years is the one peak, and another can occur at any age, right? So when I go to diagnosis of autoimmune hepatitis, I have to see four factors. First of all, very important, presence and titers of autoantibodies. We see ANA, anti-nuclear antibody. We see asthma, which is anti-smooth muscle antibody. We see anti-LKM and we see anti-ALC antibodies, but these are very rare. Okay, so I think ANA, asthma, and anti-LKM is what we use in our diagnostic practice. IgG elevation is, of course, very persistent in autoimmune hepatitis, followed by very classic histologic findings, what we see on liver biopsy that I will discuss later. And of course, very important, you have to exclude the other etiologies of hepatitis. Like you have to exclude viral hepatitis by doing the viral markers, right? So this is about the diagnosis of autoimmune hepatitis. Elevation of AST and ALT about 5 to 10 times the upper limit of normal. Very important. Gamma globulins or IgG levels more than or equal to 1.5 times the upper limit of normal. Positive ANA, asthma or anti-LKM1 in titers of more than 1:80 is diagnostic. Female sex is again very much important factor. Negative markers are very important for hepatitis A, B, and C and Wilson's disease. A very important point to note that till we have excluded viral hepatitis, we do not ever give the diagnosis of autoimmune hepatitis. So this particular criteria is also very important. Nextly, alcohol consumption of less than 25 grams per day. Now this is going to exclude the possibility of alcoholic steatohepatitis. Right, so this criteria is also very important. Again, absence of hepatotoxic drugs is again one thing we need to exclude because many of the hepatotoxic drugs they cause hepatitis. So after excluding viral markers, after excluding the alcohol consumption quantity, after excluding the drug history, if we have all these criteria present, then we diagnose it as autoimmune hepatitis. So this is a very simplified diagnostic algorithm for autoimmune hepatitis. So as I said, we have an acute or chronic elevation of transaminases, that is ALT and AST of unknown cause. We have excluded hepatotoxic drugs. We have excluded that alcohol use is not much more. We have excluded hepatitis B, hepatitis C, Wilson's disease, hemochromatosis, which is a storage disorder, alpha-1 antitrypsin deficiency, NASH, which is again non-alcoholic steatohepatitis. So all this we have excluded. Yeah, if we have alkaline phosphatase and bilirubin also elevated, we have to again exclude PBC, which is primary biliary cirrhosis, and PSC, which is primary sclerosing cholangitis. So after we have done all of this, and if all of these things are negative, so then we go to the screening of autoimmune hepatitis. For screening, we need all these things. We need ANA antibody, anti-smooth muscle antibody, anti-liver kidney microsomal antibodies, gamma globulin, and IgG levels. All of them, if they are negative, AIH is unlikely. Then you may consider some non-conventional antibodies like anti-SLA-LP, anti-LKM3, and anti-LC1. Okay, so if all of them also don't give you the diagnosis, you have to consider liver biopsy to confirm the diagnosis and severity of liver disease. And if all these autoantibodies, if they come out to be in the titer of more than 1:80, if your gamma globulin IgG elevation is more than 1.5 times the upper limit of normal, of course it is likely to be autoimmune hepatitis. You will confirm the diagnosis by the liver biopsy. So as we are seeing in this diagnostic algorithm, the liver biopsy is playing a much important role in confirming the diagnosis, right? So, yes, so we have two types of autoimmune hepatitis here, type 1 and type 2. In type 1, conventionally we do the conventional antibodies like ANA and asthma, non-conventional PNK and anti-SLA-LP. SLA-LP is anti-soluble liver antigen and anti-liver pancreas antibody. right? And if it is type 2, we do mostly anti-LKM1. Yes, there is a conventional antibody. If it is negative and we are still suspecting it to be AIH, then we go to the non-conventional antibodies like anti-LC1, which is anti-liver cytosol 1 antibody, anti-LKM3 and anti-SLA-LP. Yeah, so this is the primary diagnostic antibody and this is the secondary antibody. So as I said, liver biopsy is very, very important in diagnosis. So this is just a short review of histopathology of the liver biopsy. So this is basically a normal liver, which is showing a normal portal triad, right? This is one hepatocyte and this is a central vein. And here you have the portal triad of bile duct, hepatic artery and vein, right? Portal vein. So here on histopathology, we see it like this. We have a portal vein seen here with the hepatic artery and the bile duct, and this is all the portal triad, right? Now, if you see in autoimmune hepatitis, this portal triad, there is much lymphocytic infiltration. The degree that you can see it even on the low power of microscope, right? So this is what we do. And if the severity of the autoimmune hepatitis is more or it has progressed to a chronic stage, then we can see the lymphocytes are even invading the limiting plate. They are spilling out of the portal triad and they are going beyond the limiting plate to infect the other liver tissue also. Right? So this is all about the liver biopsy in autoimmune hepatitis. Because there is an inflammation, there is a chronic inflammation, so we are expecting lymphocytes in the liver biopsy. So many a times the diagnosis of autoimmune hepatitis is not very, very straightforward, right? So there are many variations even in the titers of the autoantibodies, right? So in that time, we have this score to help us, okay, in differentiating the between the probable AIH and a definite AIH. So we have the autoantibodies. So if ANA or SMA is more than 1:40, we have +1. Similarly, if the titer is more than 1:80, it goes to +2. If LKM1 is also positive for more than 1:40, again it goes to +2. SLA-LP positive, any titer is going to give a +2. Gamma globulins level more than upper limit of normal and is +1, but it is if more than 1 to 1.5 times upper limit of normal, then it goes to +2. Liver histology compatible with AIH, like if you are saying lymphocytic infiltration very, very prominent in the portal triad and it's going above the limiting plate of the hepatocyte, then it is +2. Compatible with AIH is just lymphocytes. Typical of AIH is the lymphocytic infiltration, again going beyond the limiting plate, +2. Atypical is you can just see few inflammatory cells, but then it is not diagnostic, then it is 0. Absence of viral hepatitis, if it is there, then it is 0. But if you are excluding hepatitis, then it is +2. So all this, when we total out, if you're getting a score of 6 or less than 6, then it is probable AIH. But then if you're getting a score of 7 or more than 7, then it is definitive autoimmune hepatitis. Next autoimmune disease in liver that is very important is primary sclerosing cholangitis and primary biliary cholangitis. Now these two diseases are very, they overlap in their characteristics, but then there is a very basic difference in these two diseases that we will understand in very shortly. So basically primary sclerosing cholangitis can affect at any age. More than 60% of them are men, and very important is primary sclerosing cholangitis affects the bile ducts inside and outside the liver too. 80% of them have a association with the inflammatory bowel disease, and the diagnostic criteria in the primary sclerosing cholangitis is MRI of the bile duct. More than any blood test, for PSC, we go for MRI. There is no medical treatment available for PSC, and these people are at elevated risk of bile duct and colon cancer along with primary sclerosing cholangitis. In that, when compared with primary biliary cholangitis, there is mostly a middle-aged disorder. In this, there is a female predominance, right? And very important difference is it is affecting the bile ducts only inside the liver and not outside the liver. 1%, only 1% of them have an association with inflammatory bowel disease. Here we have a blood testing criteria, that is, we do an anti-mitochondrial antibody. Along with that, we see raised alkaline phosphatase in the blood test, right? And here medical treatments are available. So this is a less severe disease than PSC. Okay, so these two very important. I think we all have discussed this. I will just go to the blood test. Liver function test here in primary biliary cholangitis, we can get a cholestatic picture. There is a raised alkaline phosphatase and there is a raised GGT, which is gamma glutamyl transaminase. In the primary sclerosing cholangitis also, we get a cholestatic picture. If you do a liver function test, you will get a raised ALP and GGT. But what is again going to show a difference is the anti-mitochondrial antibody, which is a M2 subtype, which is very much predominant for this PBC. 98% of PBC patients, they show AMA M2 subtype positive. And here we don't have any blood test which is diagnostic for PSC. So we do ERCP and MRCP, which will show beaded appearance of the bile ducts. Because the bile ducts have sclerosed, they are going to show beaded appearance. Right? Associated conditions we have already discussed. So if I have to only talk about diagnosis, these two things are very important. Going to GIT, we have first of all atrophic gastritis, very, very important autoimmune disease in the GI. The autoantibodies against the gastric parietal cell, we diagnose it by indirect immunofluorescence study. For pernicious anemia, it is intrinsic factor, salivary duct cells and gastric parietal cell autoantibodies. Here we do a radioactive vitamin B12 binding assay along with IFM. Right? Ulcerative colitis, we have an autoantibody against the colon lipopolysaccharide, right, which is a DNA sensitive PNCA associated autoantibody. Here we do detection by IFM and ELISA. Even Crohn's disease, the autoantibody which is checked is ASCA, IgA and IgG, and here we again do it by ELISA. In celiac disease, the autoantibodies against the tissue transglutaminase, Ig endomycyl protein, and deaminated gliadin peptides. And here also we use IIFM and ELISA for detection. So if I have to go in detail about the autoimmune atrophic gastritis, what has to be done? So whenever we are suspecting a corpus predominant atrophic gastritis, now there are two scenarios in this situation. It can be associated with H. pylori infection or not associated with H. pylori infection. So in both of the terms, we are going to see how the diagnostic criteria differs. First of all, if you are having a concomitant H. pylori infection with the atrophic gastritis, the first step is you have to treat the H. pylori infection. Yes, and with that, first of all, because H. pylori infection we know causes anemia, we have to go to the lab test of CBC to check whether there is anemia or not, and we have to do anti-IF antibodies and anti-PC antibodies, right? So if on the CBC I see that there is no anemia and there are no antibodies, I go to diagnosis of multifocal atrophic gastritis. But if I am seeing macrocytic anemia on CBC, if I am seeing the antibodies to be positive, then I have to diagnose it as autoimmune gastritis. Again, to confirm that, I have to measure the vitamin B12 levels. If they are low, you again give it a diagnosis of autoimmune gastritis with pernicious anemia. If again the vitamin B12 levels are normal, then we have to again check it by methylmalonic acid and total homocysteine levels. Right? So if these levels are absolutely normal, then you have only autoimmune gastritis as your diagnosis. There is no pernicious anemia associated. But again, if these levels are low, then it again means that there is a pernicious anemia component present along with autoimmune gastritis. So this particular algorithm is very important because atrophic gastritis many a times is associated with H. pylori infection and pernicious anemia. So very important this algorithm is. So the main clinical manifestations of autoimmune gastritis, hematological, as I said, macrocytic anemia. The macrocytosis is not associated with anemia here. Yeah, there is iron deficiency. There can be hemolytic anemia also present. There can be pancytopenia present. Leukemoid reactions are possible in autoimmune gastritis. There can be thrombosis associated with hyperhomocystinemia. In GI manifestations, they have the symptoms of dyspepsia associated with the motor disorders, and they mostly tell patients that they have a reflux, gastroesophageal reflux. In psychoneurological manifestations, they complain of peripheral polyneuropathy, myelopathy, neuropathy of optic or auditory nerve, vegetative dysfunction, depression, and cognitive impairment. So all these manifestations are seen in autoimmune gastritis. This is what we see on the biopsies for autoimmune gastritis. Basically, this is the biopsy from the gastric body, and this is a periodic acid shift stain which we see for the mucus-producing cells in the intestine. So, as you can see here, this all the magenta colored nuclei, they are basically the mucus-producing cells in the place of Pundik cells. So, normally in stomach, we don't have the cells that produce the mucus. This is basically, they are present normally in the intestine. But here, because of the gastritis, autoimmune gastritis, there has been metaplasia. The intestinal lining mucus producing cells have been found in the stomach also. Right, so this is a very severe pseudopyloric metaplasia we can see here. And instead of Pundik glands, you can see here, these are the mucus producing cells seen as in the intestine. So very, very important change that we see in stomach in autoimmune gastritis. Next, two important entities again in GIT which are autoimmune, which is ulcerative colitis and Crohn's disease. So ulcerative colitis is basically limited to the large intestine and the colon, right? But Crohn's disease can be in anywhere in the GI tract, right from the mouth to the anus, right? In ulcerative colitis, the inflamed areas are continuous. Okay, there is no patchiness. Here you can see, because there is a large part of the GI tract involved in Crohn's disease, you can see the inflammation in patches. The pattern of inflammation, ulcerative colitis, the patient typically tells that he has a pain in the lower left abdomen. And here, in the Crohn's disease, they have a pain in the lower right abdomen, right? So here in ulcerative colitis, the ulcers, they penetrate the inner lining of the abdomen only. Whereas Crohn's disease, it is going to penetrate the entire thickness. Bleeding is very common in during bowel movements in ulcerative colitis, but in Crohn's disease, it is uncommon. So why I am discussing this? Because all these things are very important in the primary evaluation of a patient who is suspected ulcerative colitis or a Crohn's disease patient. So if I have to tell them in pictures, is ulcerative colitis, okay, which is infecting only your large intestine, whereas this is your Crohn's colitis, is the patchy inflammation. It can affect the GI tract from anywhere, from the mouth to the anus. This is a stricture which is formed because many a times this is a patchy inflammation, and because the ulcers are involving the whole wall of the intestine, you can see the strictures in Crohn's disease. These strictures are not much common in ulcerative colitis, because in ulcerative colitis, the ulcers are only involving the inner lining of the mucosa. Yes. So a patient has come to you, and you are suspecting that patient to be an IBD patient, inflammatory bowel disease patient, and you have seen that even the liver test for him is abnormal. So now how to go forward in the diagnosis? So first of all, the emergency criteria, of course, I have to assess whether the patient is an encephalopathy, whether the patient is having sepsis, whether the patient is having coagulopathy. If all these three are present, if any one of this is present, then we have to refer the patient to an acute care assessment because it's an emergency situation. But if if all these three things are not present in the patient, then you have to repeat again the liver profile, right? Again, you repeat the liver profile. Again, you have the persistent abnormalities in the liver profile. Then, if the persistent abnormality is not there now, if the LFT is normal now, you can discharge the patient. But again, you got an abnormality in the hepatic profile, right? So now you have to see the hepatocellular pattern and the cholestasis pattern. Yeah. So if there is a hepatocellular pattern on the liver biopsy, we have to go to steatosis, NASH, and all these things we have to suspect. If there is a cholestasis pattern, then we go for PSC and PBC diagnosis, right? So this is I am talking about the whole GIT autoimmune disease workup, right? So this I think you can always talk to a pathologist that whether the liver biopsy is showing the hepatocellular pattern or a cholestatic pattern, right? So if it's a cholestatic pattern, you have to go to the autoantibodies of AMA, and you have to always go for MRCP also. And along with this, if the study is negative, then you can do liver biopsy also. Here, if it is a hepatocellular pattern in the LFT, then you can always go for these antibodies like ANA, ASMA, LKM1, IgG, as we already discussed. Also do the viral markers in these cases. If all of them are negative, then you have to consider the liver biopsy. So this is all we can do in a GI workup of autoimmune diseases. So we start with the LFTs. We assess the LFTs. We assess the autoantibodies, and then depending upon the results of LFT and autoantibodies, we decide whether we have to go for liver biopsy or not. And liver biopsy is the confirmation diagnosis. This is a histology liver biopsy in Crohn's disease and ulcerative colitis. In Crohn's disease, now this is a mucosa of the intestine, and this is a submucosa. You can see the granulomas, which we can see in the Crohn's disease. It's a chronic granulomatous disease. And in ulcerative colitis, you can see this is a mucosa, and you can see much inflammation, which is including neutrophils. There are many neutrophilic crypt abscesses which are seen in the ulcerative colitis. So this is very diagnostic. The biopsy is basically diagnostic in many autoimmune diseases. But just because it's an invasive procedure, we always keep it as the last option for confirmation of diagnosis. Lastly, we are going to talk about the celiac disease, right? So if you're suspecting it to be a celiac disease, then of course, if you get a patient with the persistent symptoms of celiac disease, then you have told the patient that you have to get a gluten-free diet, and even the gluten-free diet is not working for the patient. Then what can we do in the celiac disease? So how to confirm the celiac disease? First of all, supporting evidence we have is positive EMA or tissue transglutaminase antibody positive, presence of HLA-DQ2 or HLA-DQ8, family history of celiac disease is present, biopsy has proven dermatitis herpetiformis, there is a history of clinical and or histologic response to gluten-free diet. If all this is present, if yes, then we have to label it as a non-responsive celiac disease. What can be the other causes of the non-responsive celiac disease? It can be gluten contamination, it can be bacterial overgrowth or microscopic colitis. If any of them is not present, then you have to go whether it is any malignancy and you go for biopsy. If there is no malignancy, then we label it as a refractory celiac disease. In refractory celiac disease, more than 50% or more than 20 to 25% of intraepithelial lymphocytes are present, and there is an abnormal immunophenotype which is CD3, CD8 positive, which is confirmed by IHC or flow cytometry respectively. So when I had said that flow cytometry is important in autoimmune diseases, that is the picture which is seen here. In rare cases, of course, but we may need flow cytometry in the later stages, right? So if this is not present, it is refractory celiac disease type 1. If this is present, if this is CD3 CD8 positive, there are IEL, which is intraepithelial lymphocytes, then it is a refractory celiac disease type 2. However, if all of these components are not present, then you have to go for other causes of bilious atrophy associated with severe symptoms. And in that, we have adult onset autoimmune enteropathy, we have collagenous sprue, tropical sprue, hypogammaglobulinemic sprue, eosinophilic enteritis. If this is not present, then it is classified as unclassified sprue and it is given just an empiric treatment. If all of these are present, you have to treat them accordingly. Right? Even here, if there is a other causes of non-responsive celiac disease is present, you have to treat them accordingly. In malignancy, if you are suspecting, then you have to go to the clinical staging of the malignancy and consult the oncologist or hematologist or a surgical oncologist for the grading. So all this is about the celiac disease. The workup of celiac disease is very tedious and very big till you confirm the diagnosis. But then there are some cases which show no response to gluten-free diet, and in that cases we have to do all this workup for celiac disease. As far as the neurologic autoimmune diseases are concerned, we have two very important diagnoses. The first is the myasthenia gravis, where we have an autoantibody against the acetylcholine receptors. The detection methods for this is the immunoprecipitation technique. Next is the multiple sclerosis. It's a demyelinating disease. Here we have autoantibodies against the myelin tubulin, myelin basic protein, which is MBP, and myelin associated glycoprotein. Here also the detection methods we have is IFM, ELISA, and immunoblotting. So this is the way by which we detect these autoantibodies in these two conditions. For thyroid gland, very, very important, we have autoimmune thyroiditis, right? Again, we do anti-TPO antibodies, yeah, anti-thyroid peroxidase antibodies and anti-thyroglobulin antibodies for detection of autoimmune thyroiditis. Detection methods are again by IFM, by ELISA, which is very commonly used. We can also use passive hemagglutination and latex agglutination. For Graves' disease, in Graves' disease, we have autoantibody against the TSH receptor itself, right? So for that, we do the radioreceptor binding assay, which is a cyclic AMP bioassay. By this, we can detect the autoantibody against the TSH receptors. So these two are very important for thyroid. Autoimmune thyroiditis, again, I think many of the clinicians must have seen these patients. So there, mostly the thyroid function tests are normal. Sometimes the TSH is elevated and T3, T4 are normal. So that is called as the subclinical hypothyroidism, where we have TSH slightly elevated to the point of 5 or 6 and the T3, T4 are normal. If such patients are not treated at the right time, then they can again go or progress to hypothyroidism, which is showing any symptoms, clinical hypothyroidism. So it is very important that we catch autoimmune thyroiditis at the level where only TSH is elevated and T3, T4 are normal. And anti-TPO is the test of choice to be done in such patients. In adrenal gland, you have the Addison's disease, in which we have autoantibody against the adrenocortical antigen, and IFM is a detection method of choice for it. In parathyroid gland, hypoparathyroidism may be sometimes of autoimmune origin. Here we have autoantibodies against the parathyroid endothelial proteins, and the detection method here is the indirect immunofluorescence method. For pancreas, very, very famous autoimmune disease is the type 1A diabetes mellitus, where we have autoantibodies against the islet cells and insulin-associated antiglutamic acid decarboxylase, against this enzyme and against the islet cells. So here we do ELISA mostly, or we can do immunofluorescence study, indirect one, or radioimmunoassay. In muscle, dermatomyositis and polymyositis is an entity which is again autoimmune related. Here we have autoantibody against the PM1 and Jo1 antibody, and ELISA and immunodiffusion are detection methods of choice. Now we have just went through the organ specific diseases. Now we will go to the systemic diseases, and in that we are going to cover two very important diseases, that is SLE and rheumatoid arthritis. Now, first of all, SLE, when you get a patient who is a suspected case of SLE, how we are going to go through the diagnosis? Of course, the first test we all need is ANA for SLE, right? So test for anti-nuclear antibody by immunofluorescence, right? So you are going to apply the criteria, that is EULAR or ACR score, along with the ANA result to go to the diagnosis, right? So ANA positive or ANA negative, this can be the two outcomes of the ANA test, right? So then we go to the score. Now, there are some clinical domains that they have prescribed. It is the constitutional symptoms includes the fever. If the patient has fever, the points are 2. If the hematologic may, we have leukopenia, thrombocytopenia, and autoimmune hemolysis. So we have points for all these 3. For neuropsychiatric manifestations, we have delirium, psychosis, and seizures. For mucocutaneous, we have non-scarring alopecia, oral ulcers, SCLE or DLE, and ACLE. And in immunologic domains, we have the low C3, or this is a complement basically, a complement study. Low C3 or low C4 is 3, low C3 and low C4, both of them are low, then it is 4. SLE specific antibodies like anti-double stranded DNA or anti-smooth muscle antibody is also positive along with ANA, then the score is 6. Again, for serosal, if you have effusion, it is 5. Acute pericarditis, it is 6. Musculoskeletal joint involvement, the weight is 6. Renal manifestations, again, proteinuria, 4. Renal biopsy showing class 2 or 5-LN, it is 8. Renal biopsy showing class 3, it is 10. So renal biopsy may we see the severity of the disease, right? The clinical score can go anywhere from 0 to 39. And of course, the antiphospholipid antibodies can, if they are present, then the weight is 2. So we have a clinical score which is consisting of all these parameters. We have immunologic score which is showing all these parameters. Clinical score of 0 to 39 plus immunologic score of 0 to 12. The total score can go from anywhere from 0 to 51. Right? So this score, if it is more than or equal to 10, with at least one clinical criteria, right? So here you have also to see that whether all immunologic criteria are only present or only all clinical are present, right? So here if we have the score of more than or equal to 10 with at least one clinical criteria, it is classified as SLE, right? So if your score ANA is positive and your score is less than 10, in that now you have to bifurcate. If your immunological score is 0 and clinical score is more than or equal to 8, plus there is ACR 97 photosensitivity, or immunological score is more than or equal to 2 and clinical score is more than or equal to 6, then it is a clinical SLE. Right? So both of the things is SLE only, but you have to just see the score and classify the patients. If ANA is negative, you do the complement test, right? Hypocomplementemia is the present, or if there is a positive APL, this is the alternative entry criterion. Along with that, if you have a score of more than or equal to 10, and at least one clinical criteria. Even if you are ANA negative, you can be diagnosed as clinical SL. And while considering all these features, also consider some non-criteria features like Raynaud's disease or myocarditis or atypical rashes in patient of SLE. So a bit tedious workup of SLE, but very, very important. So the clinical evaluation along with the lab testing is very important, and it is very true when it comes to SLE, right? So this is the criteria for rheumatoid arthritis now. For rheumatoid arthritis, we always follow the criteria for the American College of Rheumatology, right? The target population is the patients with definitive clinical synovitis in at least one joint, with no alternative diagnosis better explaining the synovitis, right? So in that you can see the joint involvements. If only one large joint is involved, the score is 0. Similarly, we can, if the joints keep on increasing, the score goes on increasing. Serology, at least one result we need, that is we do the rheumatoid factor and we do the ACPA. If it is positive, both of them are highly positive, the score goes high. In acute phase reactants, if you have normal CRP and normal ESR, the score is 1, but if they are abnormal, the score goes, it's 0. And if the abnormal CRP and ESR is present, then the score is 1. Duration of symptoms, very important. Less than 6 weeks is 0, but more than 6 weeks is 1. So all the points added, if the cutoff score is more than or equal to 6 points, it gives a definite diagnosis of rheumatoid arthritis. So always in autoimmune disease, as I already said, it is a combination of the laboratory evaluation and the clinical evaluation. So when you clinically suspect a patient for rheumatoid arthritis, how to go about the diagnosis, right? So ACPA, that's the autoantibodies to circulated protein and peptide antigens. So this is the test you are going to talk to the lab, right? So ACPA, if it is positive, again most likely to be RA. So there is no doubt in that. But if ACPA is negative, then we do the rheumatoid factor. Or else, if you have a clinical suspicion of rheumatoid arthritis, you can directly go to a rheumatoid factor also, right? Rheumatoid factor, if it is positive, then again the diagnosis is very straightforward. It is rheumatoid arthritis. But if it is negative, then you order autoantibodies against RA33. If it is positive, confirm the diagnosis. If it is again negative, then it is not rheumatoid arthritis, but it is not impossible. You can evaluate further after some weeks, right? The next option we can have is the ANA antibodies, right? If it is negative, then there is no suspicion. But if it is again positive, then you have to have the differentiation of ANA. You have to test for the autoantibodies against the ROLA, which we call very commonly, which is SSA and SSB autoantibodies, which goes for the Sjogren's syndrome if it is positive. If the SM-DS-DNA and autoantibodies are positive, then it is most likely to be SLE. If the ACA or scleroderma 70 autoantibody is positive, then it can be a scleroderma. Okay, so along with rheumatoid arthritis, there are some very common, less common diseases that you should always take into mind when you are evaluating a patient of joint pain, right? So here, the most important initial test for a patient with a joint pain is rheumatoid factor and ACPA. If you have completed the workup of these two and you're not getting any diagnosis, you can go to the ANA testing and then you can go further to the less common diseases. So that is how it is going to be there. Now, a very another important entity, which is again autoimmune, it is Apla syndrome, which is antiphospholipid antibody syndrome. Here, in clinical criteria, as you all may be knowing, there is a vascular thrombosis, right? More than one or more than one arterial, venous, or small vessel thrombosis. Pregnancy morbidity The patient should have at least one or more than one fetal deaths, which is at or beyond 10th week of gestation, more than or equal to one premature birth before 34th week of gestation because of eclampsia or severe preeclampsia or placental insufficiency, or 3 or more than 3 consecutive pre-embryonic losses before the 10th week of gestation. So this is the clinical criteria which we assess, right? Laboratory criteria, in that we have the lupus anticoagulant positivity present in the patient on more than or equal to 2 occasions, done at least 12 weeks apart. So very, very important. Once we do the antibodies and if it is positive, we cannot diagnose the patient as Apla syndrome. 2 tests are needed to be done, at least 2, minimum 2 tests we have to do, and that 2 tests should be 12 weeks apart. Right? So lupus anticoagulant antibody positivity, which is on 2 occasions done 12 weeks apart. Anti-cardiolipin antibody, either IgG or IgM, in medium or high titer. When I say medium titer, it is more than 40 and above that, right? On 2 or more occasions, again at least 12 weeks apart, right? So, and third is the anti-beta 2 glycoprotein 1 antibody against IgG or IgM. In medium or high titer, again above the 99 percentile. Again here we have more than 1:40. On 2 or more occasions, at least 12 weeks apart. So in Apla syndrome, you can see all of the laboratory criteria have value only when they are tested 12 weeks apart. So always we have to have 2 tests done, right? So definite APS, antiphospholipid syndrome, is present if at least one of the clinical criteria is present and at least one of the laboratory criteria is met. Right? So this is a little tedious diagnosis because you have to wait 12 weeks apart for 2 tests to be done, and one laboratory criteria is absolutely essential to diagnose. Okay, so you will need minimum 12 weeks to diagnose an Apla on paper for the patient. Right? So there are some cases which are seronegative, right? So they don't show any positivity, no lupus and nothing, right? But they have antiphospholipid syndrome. Okay, so in that, how to know, how to diagnose a seronegative antiphospholipid syndrome? Then you have to look for signs in the other systems, right? Other than thrombosis, right? So in nervous system, they have dementia, they have seizures, they have multiple sclerosis-like illness, they have chorea, they have myelitis, right? In skin, they have, this is very typical, livedo reticularis, right? This is very typical. Livedoid vasculopathy is another thing which is present in the skin. In heart, we have valve vegetations or thickening, which is called as a Liebman-Sachs endocarditis, yeah, and diastolic dysfunction in the heart. Right? So if you're suspecting a patient to be a Apla syndrome patient and you have not got any positivity in the autoantibodies, then you have to get a 2D echo done of the patient to see whether they have this valve vegetations and diastolic dysfunction. Yeah, get some blood test done. In that you can see thrombocytopenia and hemolytic anemia features. Yes, then as far as your kidneys are concerned, the kidney shows microangiopathy and chronic vaso-occlusive lesions. Like there is atherosclerosis of the artery supplying to the kidneys, glomerular ischemia, interstitial fibrosis, and arterial fibrous intimal hyperplasia. So all of them, they are going to manifest as decreased blood supply to the kidney. And decreased blood supply to the kidney can be diagnosed by low eGFR, right? So whenever you are suspecting a patient to be a seronegative Apla, you have to order the investigations like CBC for thrombocytopenia, hemolytic anemia. You have to clinically examine the patient for the skin lesions. You have to clinically examine the patient for nervous system disorders. You have to get a 2D echo of the patient done, and you have to do a whole kidney profile of the patient, which involves the BUN, the creatinine, right? And eGFR is very important, which will tell you a rough idea about the glomerular filtration rate. Of course, if there is a sclerosis or there is a thickening of the artery supplying to the kidney, there is going to be a low GFR. Creat will be a bit high on the higher side, which will again give you a suspicion that the kidneys are not getting adequate blood supply. Right, so this is also very important. There have been cases of seronegative APLA, and they have been diagnosed on this all the manifestations. So after we have seen all the organ-specific autoimmune diseases, we have seen two systemic diseases like SLE and rheumatoid arthritis. We have to throw a light on some general considerations in laboratory testing when it comes to autoimmune diseases, right? Like when I say the muscle enzymes, there is increase in muscle enzymes like creatinine kinase or AST or ALT in some autoimmune inflammatory myopathies also, right? Like dermatomyositis, polymyositis, inclusion body myositis, this will show an increase in the muscle enzymes, right? Serum protein levels are very important in autoimmune diseases because they help to screen for abnormal elevations of immunoglobulin. So that is another important test for autoimmune. Urine study is also very important. Whenever there is an anti-GBM glomerular nephritis, it will show proteinuria, hematuria, or it will show an active sediment after centrifugation. And white blood cell cast and red blood cell cast are very prominent or predominant in autoimmune kidney disease. So urine analysis is very important for anti-GBM glomerular nephritis. Next, inflammatory markers. Now, because all the autoimmune diseases, the main thing that is there in all of them is inflammation. So inflammatory markers are very important. Now, these inflammatory markers are basically, they are the serum proteins that are produced in response to inflammation. And these are mainly produced by the liver. There is they are called as acute phase reactants, right? So there is something like a pro-inflammatory cytokines like interleukin 1, interleukin 6, TNF alpha. They will induce synthesis of some of these acute phase reactants. And most important of them is CRP. So along with ESR, the CRP is also raised. Serum albumin, it decreases. A very important feature. I think in all autoimmune diseases, we have seen the serum albumin was consistently low in all of them. So a simple LFT, which includes the albumin, can give you a diagnosis or can give you a suspicion of autoimmune diseases. So the typical picture of LFT is the albumin is decreased, the total protein is maybe normal or decreased, the albumin is decreased, the globulin is increased. And there is a reversal of the albumin globulin ratio. Normally, which is 1 or more than 1, the ratio goes to less than 1. The globulin fraction increases, right? So that is again an indication of autoimmune diseases. There is an increase in ESR, that is a one condition. And why I would prefer CRP over ESR is not a time-sensitive measurement, right? And it is also affected by some other serum components, right? But CRP is the one test whose measurement is not time-sensitive, right? In ESR, we have to take the reading after 1 hour, right? So there may be some, the technical errors, or there may be many errors in ESR. And there can be many physiological variations in the reading of ESR. But CRP is a not time-sensitive measurement and is not affected by any other serum components. And the magnitude of the CRP is directly proportional to the magnitude of the inflammation. So it gives a very fair idea of whether the inflammation is present or not present. And if it is present, then what is the severity of that inflammation? Right? Less than 0.2 milligram per DL be considered to be normal, while those more than 1, they are suggestive of inflammation or infection somewhere. But more than 6 is, if you get a CRP level, then it is surely inflammation or infection somewhere in the body, which is suggestive of something that needs to be treated. Right? So CRP, we rely much for autoimmune diseases. So I think we go to the end of the session, and while doing the end, I'll just like to quote one sentence. The growing epidemic of stress, lifestyle diseases, and autoimmune diseases has a simple root cause, and it's really an epidemic of not loving the self. So I think autoimmune diseases, maybe they run in families, or they have a family history, or there may be some etiologies which are not known till now. But stress for a longer time has been the most important factor which is involved in the pathogenesis of autoimmune diseases. And I think it's just an epidemic of ignoring one's health and taking too much stress of all the things. So I think that again needs to be tackled. Autoimmune disease, I think it's a wide spectrum, right? Starting from clinical evaluation to diagnosis and treatment. And I think all the criteria we discussed in today's lecture, and maybe we will discuss in the upcoming lectures, are very important for successful treatment of this autoimmune diseases. So thank you so much for all your attention and patience. If you have time, we can take some questions if somebody has.
Thank you very much, madam, for this informative and elaborative session. If anybody is having question, you may ask in chat box or directly with mic.
Yes, I think somebody has asked some question. It's regarding the rheumatoid factor.
Hello, ma'am.
Hello, yeah, ma'am.
Yeah. I just want to know regarding RA test. Many patients they come with us with RA negative, but they have the sign symptoms of swelling and pain in the joints. So, what to consider whether they are suffering or not?
Yes, ma'am. So actually, there can be situations where RA may be negative and they may be having rheumatoid arthritis. So in that situation, I think the only one option we have is we have to repeat the test again after 6 weeks to confirm the diagnosis. And as I gave the whole algorithm of the rheumatoid arthritis, that is how many joints are involved, what is the ESR and the CRP, and all these things need to be taken into consideration. The chart which I had told, right? So ESR, CRP, number of joints involved, all these things are also important. And even if the patient is RA negative and all these symptoms are there in the patient, then you can treat them as rheumatoid arthritis.
Okay. Second thing, madam, when we tell the patient to do so and so n number of tests, he is not willing to do because regarding the cost price of the test. So any test which is a little bit lower in cost, which we can tell to the patient. So can we get some idea of the test, prices of the test? Can you just write in the WhatsApp group or something like that? So can we too can have some idea of it?
Yes. I can just give you a rough estimate. It's like if you go for autoantibodies. Autoantibodies testing is actually a bit higher price because, as we discussed, all of them are either immunofluorescence or ELISA. Right. So these are all these techniques are very costly, so the price is much. But initially, if you have to start the treatment, you can actually start it on the clinical evaluation, whatever you have done on the patient. Plus, basically, you can do CBC, LFTs, ESR, and CRP. And if it is GI related, you can go for that test also. These are some basic tests that will give you an idea about what is the patient what going through. Right, you can start the treatment. Later on, if you feel the need that yes, autoantibody is needed, a single autoantibody, I think, is the cost is ranging from somewhere 3,000 to 4,000 rupees for a single autoantibody.
Okay.
So I think yes. So I think we can choose one best antibody for one disease, and that can help us. Like if you are suspecting a patient to be having a PSC or PBC, you can choose an antimitochondrial antibody, which is AMA, and not doing the other antibodies. Right, so choosing the correct autoantibody can save the cost of the patient, can save the time, and we can get the diagnosis early.
Okay.
Like for
Thank
SLE,
you.
we can only go for ANA first. Like that.
Thank you, madam, very much.
Yeah. I can see one question here. We'll take some questions which are coming here. If thyroid antibody titer is more than normal, is hypothyroidism curable? Yeah, thyroid antibody titer is more than normal. That means I think we are talking about anti-TPO. So that is again autoimmune thyroiditis, and of course it is not curable, I will say, because again, if the titer is positive, it is an autoimmune disease and we cannot reverse the disease, neither it can be cured. But of course, hypothyroidism can be kept in check, right, with the medications, and you have to tell the patient to take the medication regularly, and you have to monitor the TFTs every 6 weeks or every 3 months, and see that the T3, T4 and TSH are always normal. So it is not curable, I will say, but it is manageable. HLA-B27 is again common. Consider ankylosing, it's true. I think we think also reactive arthritis. Yes, of course. So basically ankylosing spondylitis, reactive arthritis, all these things are also there. These are basically differential diagnosis for rheumatoid arthritis, right? So clinical evaluation in these patients is very important. Like ankylosing will give you a clinical symptom of a lower back pain, which is very persistent. Reactive arthritis will be again the particular local area will be swollen, it will be red, and the patient will be toxic. He will be in sepsis. So clinical evaluation is more important in these DDs, in this differential diagnosis. Any investigations for nervous system? Yes, ma'am. For nervous system, the blood test may not help you. Only autoantibody workup can help you when it is for nervous system. As we said, for example, if it is myasthenia gravis, we have to do the autoantibody workup against the anti-acetylcholine receptor autoantibodies. Other blood test will not help you in that scenario. Any more questions, anyone?
Anybody is having more question? Any question? Or else we can conclude this session.
Yeah, I think we have one question. Ulcerative colitis is autoimmune. So is there any blood test or only colonoscopy? Yeah, sir, we actually have blood test as I described. Ulcerative colitis is, we'll start with the clinical evaluation. We will see the patient's symptoms. In blood test, we can do many blood tests for that, including the CBCs, the LFTs. The stool routine is very important in that respect. If the patient is in the initial stages of ulcerative colitis, we can manage it with the workup of autoantibodies and blood test. But if the patient is in the more severe or last stages of ulcerative colitis, then of course colonoscopy is essential to see the extent of the disease. Like ulcerative colitis is mostly in the large colon and the rectum only, right? So if the patient is having severe symptoms, then colonoscopy is the option, or initial stages we can manage the diagnosis and treatment on blood test only.
Any more questions? Shall we end up with this session if no question is not there? Thank you, madam. Thank
Thank you, sir. Thank you so much for the patient listening of all. Thank you for the opportunity, sir.
Thank you.